So I'm Sarah Phillip. I'm the designated professional for safeguarding adults in the Camden Directorate. So this is level 3 safeguarding adults and Mental Capacity Act training. It's for an hour and a half. So clinicians need to do 8 hours safeguarding adults training over a 3-year period. And that can be very flexible. It doesn't have to be formal training. It may be some conferences, it may be supervision, it could be webinars. So this will contribute to, if you do need to do 8 hours, this will contribute 1.5 hours. Joanna has said you'll have certificates, so please, which is great, please put those, if you'd like a certificate, put your name and email address in the chat function. Regarding, please keep yourself on mute, just general things. If you have a burning question, as I'm going through, I will stop every 2 or 3 slides and ask if you have questions. Please do ask questions. I'm not sure how many of you will have done safeguarding adults training before, so I'm not sure how familiar this is with you, or it might be very new with some of you, in which case you might have lots of questions, which is great. So I will stop every 2 or 3 slides. Please, if you can, put your hand up, put question in the chat box. Joanna and I will try and keep an eye on that. So please don't feel afraid of asking questions. Safeguarding adults can be very much a grey area. It's not always black and white. That's why I'm here to give advice and support, and people should always check things out with other people. So you're not expected to know everything at the end of today. You're still, the thing about safeguarding is to share a concern, to discuss it, to make a decision together. So just to get that across. But if things aren't very clear, then do ask questions. This is the first time I've done this training virtually, so it's new for me too. So I'm not sure how the timing will go. If you have any feedback, please do let me know. And if there's anything that's not very clear or could be improved, please do let me know, because then I can look at that for the next session too. Okay, Joanna, next slide, please. So at the end of today, hopefully you will have developed a good understanding of the definition of safeguarding adults, what the safeguarding duties, the statutory duties are, and the types of abuse, the 6 principles of safeguarding and making safeguarding personal, which really give us a framework of how to work with adults once there is a concern. We'll just skip through some key legislation that supports safeguarding adults. We'll briefly look at safeguarding adults boards and safeguarding adults reviews, and what reviews are and how they're conducted and what might be asked of you as a professional. We'll look at information sharing and issues around that. We're looking in quite a bit of detail at the Mental Capacity Act, issues around capacity, around consent, and we'll look at referral pathways into MASH, the multi-agency safeguarding hub, which is where anyone and everyone, if they have a concern, would make a referral. So that would be to Camden Council. Okay, so hopefully you'll have some understanding. We can share the slides, I think. And there's some links in the slides for further information to guidelines and websites. So there's always that resource there. So I think we will be sharing the slides with you at the end of today. Okay, next slide, please. So the Care Act came about in 2014, and what it gave us, which was fantastic, was a statutory definition of safeguarding. Safeguarding is quite a nebulous term. Often people don't understand what it means. So safeguarding adults was really good to have this term. It's a very clear statement. It's in the Care and Support Statutory Guidance, Chapter 14. And what it says is safeguarding means protecting an adult's right to live in safety, free from abuse and neglect. So that means anyone who lives in this country has the right to live free from abuse and neglect. It's also about people and organisations working together to both prevent and stop both the risks and experience of abuse or neglect. So it's very much about partnership working, about multi-agency, multidisciplinary working, about sharing information where appropriate, and there's a preventative element to it. So if we think someone is at risk of abuse rather than experiencing abuse, then we must take some action as well. We mustn't wait until someone's experiencing the abuse or neglect. And the last statement says, while at the same time as doing that, we must make sure the adult's well-being is promoted, including having regard to their wishes, views, feelings and beliefs in deciding any action. This must recognise that adults sometimes have complex interpersonal relationships and may be ambivalent, unclear or unrealistic about their personal circumstances. So that's quite a long statement. If we look at the first bit, what it's telling us is that in any action we take, we must always have regard to the adult's wishes, views and feelings. So we must always try and establish those with the adult. That guides us what to do. But alongside that, as trying to prevent the risk, reduce the risk, establish the adult's views, work in partnership with our multi-agency colleagues, we must recognise that people have complex interpersonal relationships and they may be unclear. What that means is people may choose to stay in a relationship or have a friendship or have contact with, it's usually with a partner or a family member or a close friend where there's an element of risk, and people have that right, and we have to kind of be sympathetic to that and understand that. That last sentence was new with the Care Act, and that was brought about because previous to the Care Act we'd had kind of in health and social care a very paternalistic attitude around we knew best, you know, as professionals we knew best what was best for someone without consulting them and without really understanding that a lot of people choose to live with some element of risk in their relationships, and they have that right and that choice. Okay, next slide please, Joanna. So the Care Act placed safeguarding adults on a statutory footing. Before the Care Act, it had just been guidance. So safeguarding wasn't new, but what it did was give us a statutory framework. So it gave us the law to work within. It introduced a number of duties relevant to safeguarding adults. So it introduced a duty to cooperate, and that's really with all professionals. So it just means that all professionals should engage in the multi-agency sharing, should share information where appropriate. The board can instruct people to share information, the Safeguarding Adults Board. It's not a duty that's needed to be used often, but it's there to use if it's needed to. There's also a duty to assess adults who appear to have care and support needs. So again, adult social care must always offer an assessment to anyone who appears to have care and support needs. And likewise, they must offer an assessment to any carers that appear to have care and support needs. And they must also offer carers assessments to anyone they become aware of who is a carer. So that's not very well known, but if it's about carers' rights, so that was a big change in the Care Act where it really improved carers' rights to a carer's assessment and also to an assessment in their own right separate to their kind of caring role. It also introduced Section 42 inquiries, which really, they're called a safeguarding inquiry. It's really another term for a safeguarding investigation. It's kind of broader than how we might think of a narrow investigation, but it's similar. So if you hear Section 42, S42, it's really a safeguarding inquiry and investigation. The Care Act established Safeguarding Adults Boards and Safeguarding Adults Reviews, which we'll cover those later on. it added some additional types of abuse that we hadn't really had before. So there's 10 types of abuse, which we'll go through. And it talked about 6 principles. So they're statutory principles of safeguarding that give us a framework of how to work with abuse and neglect. Any questions so far? I think I'll stop there. Is there something I just need to check? No, nothing in the chat. I can't see any hands. If I don't see your hands, please just speak up. Okay, I don't think so. Next slide, Joanna, please. Okay, so the safeguarding duties apply to all adults who have care and support needs. So that doesn't mean the local authority have to be meeting those needs. That was previous. If someone had a care package, then safeguarding would get involved. If they didn't, then kind of the local authority and a safeguarding process wouldn't start if there was a concern. That changed with the Care Act, where it's just someone has to appear to have needs for care and support, and they're experiencing or they're at risk of abuse or neglect. And because of their needs, they're unable to protect themselves. So that's when the safeguarding duties kick in, and we as health professionals would have to think about doing something. So, okay, there's a question. Who flags people up as needing care and support? Rachel, I think that was from. Anyone can flag anyone as needing care and support. So anyone can make a referral to adult social care. So if you're a health professional and you become aware of someone as possibly having care and support needs, or they tell you, a patient tells you that they're struggling, they need some assistance, then you or they themselves, people can self-refer, friends, family, neighbours, anyone can make a referral to the local. So in Camden, it would be Camden Council Adult Social Care for a care and support assessment. Hopefully that's clear. Okay, so if those 3 conditions are met, okay, thanks, Rachel, then the safeguarding duties kick in. So it can be quite hard to think of the 3. I mean, I know the 3 because I've been working in safeguarding for about 14 years. But if you just think, has someone got care and support needs, and are they at risk of abuse or neglect, then really the safeguarding duties kick in, and you should be thinking at the very least of having a conversation with that person. So let's just go to the next slide. So what do we mean by care and support needs? It does cause a bit of confusion for people sometimes. So there's some kind of key groups where people usually have care and support needs. So what kind of things what kind of groups of people would you be thinking are likely to have care and support needs? Just shout out, put your hand up, put something in the chat. Any thoughts? Yeah, those with learning difficulties, those with learning disabilities, great. Especially people with medium to significant, great. Cognitive impairment, yeah. So that could be through dementia, could be through a head injury. Really good. Anything else? Anyone else you might come across? Physical disabilities, great. Yes, that's one. Okay, that's some really good answers. Let's go to the next slide. So bedbound patients, great. Yeah, frail and elderly, often they can be bedbound, obviously people with physical disabilities. So they're the kind of groups. I'm a social worker by background, so I always think you're trained as a social worker to think in those kind of groups, because the way social services operates is in terms of teams and departments, really, in terms of frail and elderly, learning disability, physical disability, sensory disability. So that's just people who fall into those groups tend to have some kind of care and support needs. They might not. I mean, we used to just talk about the elderly, and of course now we know the elderly don't often have care and support needs. My mum was 80 the other week and she's out walking the dog for 3 hours a day, and so far seems okay with her cognition. So, you know, being elderly doesn't mean you'd have care and support needs, but, you know, frail and elderly, the older you get. Mental mental health needs, that means more, it wouldn't mean really someone who's just got some low mood or a bit of depression. It means significant mental health needs, severe and enduring. I think that's what they term it, mental health needs. So personality disorder, schizophrenia, someone with kind of a moderate to significant dementia, someone with a significant physical disability or a sensory disability, someone with a moderate to severe learning disability will probably have care and support needs, someone with a severe physical illness. Unpaid carers, there's a lot of ill health. When we say unpaid carers, we mean it's kind of unpaid informal carers. So we're not talking about carers that are paid through an agency. It's a bit of an odd term because a lot of family and friends are now paid as carers, so they'll get a carer's allowance, but we still call it unpaid carers, informal carers, families, friends, neighbours. They're a group that has very high kind of stress levels, poor ill health, they're overburdened, they're often isolated. So they can often have care and support needs in their own right. The homeless and substance misuse often have care and support needs. Those two, not always, but often there's a high instance of substance misuse amongst the homeless. With both, there can be high instances of mental health needs, not always, but it is quite common. And of course, a lot of physical illness, if people are street homeless, tends to happen. And the other group that's kind of a new, it's not really a new group, but it's a group that we're becoming more and more aware of, are the people 18 and above, I think it's 18 to 24, who have recently moved out of children's services eligibility. So we call it transitions. And there's a lot of kind of thinking and talk in safeguarding adults. I went to a half-day conference a few months ago in Camden around transitions, and it's around how 18 years old, they lose access to a lot of support when they've always had a lot of support from children's services. They feel very much on their own, they become vulnerable, they become isolated, and they often have care and support needs too. So just to be aware of that very young adult's age, if it's someone who's transitioning out of children's services, they may have care and support needs. So that tends to be the groups really who will have care and support needs. Okay, next slide, please, Joanne. So another question, what are the types of abuse? So there are 10 types. You probably are familiar with some. So again, if you can just put it in the chat box, shout out, raise a hand. So you might think of it as categories of abuse. It's the same thing, the term with the Care Act. Yep. Neglect, great. Emotional abuse, great. Domestic abuse, another one. Physical abuse, mental abuse, emotional, financial, great. You're doing really well. Sexual abuse, fab. Any more? Can you think of any more? There's a couple that have kind of, you may have seen in the news a bit or through your work become aware of the risks. Yeah, modern slavery, that's what I was thinking of. That's kind of increased during the last 18 months during lockdown. Another one, modern slavery, great. There's a couple more, you've got most of them, just giving people a bit of time. Neglect, fantastic. Really good, really good. Okay, radicalisation, yeah, of course, prevent radicalised, but when people are groomed and radicalised to commit terrorist acts, yeah. Okay, fabulous. Joanna, can we have the next slide, please? So you got, I think, nearly all of them. So they're the 10 types. Discriminatory, organisational and self-neglect are the ones we didn't have there. So physical, sexual, psychological, domestic abuse, financial. So just domestic abuse, we've got that's domestic abuse and violence. So we tend to use the term domestic abuse rather than domestic violence to incorporate the coercion and control that we know, can often comes before the violence, not necessarily always, but some people may be experiencing coercion and control without the violence, the domestic violence. That's still domestic abuse, and we've just got, I think this year, the Domestic Abuse Act, which is great, which again adds lots of statutory duties and puts it on a very strong legal footing. Financial abuse that's increased during lockdown, so you probably read some of the things, the atrocious NHS scams, all those kind of things. It's fraud, it's theft, it's scams. One of the, it's probably quite common, more than people realise, is what we call familial financial abuse. So that's where family members are financially abusing their loved one, and it often takes the form of family members helping themselves to the vulnerable adult's money, and often quite large sums. And what they will say is, well, it's, you know, if it's the son or daughter or grandchild, they'll say, well, it's my inheritance, but that person hasn't died. So, and it's illegal to take their money while they're still alive if they haven't given it. If they lack capacity and can't give it, or they haven't given it, then it is a crime and it's illegal. So it's quite a sensitive area. I used to oversee a lot of safeguarding investigations, and there'd often be quite a lot of those. Half the families would say, oh, I didn't realise. The other ones would say, oh, I did. And generally they give the money back or stop. But just to be aware of that. Another one is where family members can just be doing the shopping, or carers, paid carers, unpaid carers. It's not uncommon. They'll be doing the shopping every week and, you know, help themselves to £10-20 a week, or buy some cigarettes or a bottle of vodka with the money. That kind of falls into the realms again of financial abuse. If it was a family member, we'd tread very carefully if it was small sums of money, but I'll come on to that later. The other one which was mentioned is around modern slavery, so human trafficking, forced labour. So we know it goes on a lot. It goes on through across countries. It goes on within the country. So within this country, it goes on quite a lot. We have seen it increase, but personally, I'm not sure if it's just we've become much more aware of it over the last few years. Discriminatory abuse incorporates, it's when discrimination occurs because of age, culture, ethnicity, gender, disability, sexuality, all those things. So often we find within safeguarding adults there'll be discriminatory and another type of abuse, but not necessarily. Organisational is where the organisation is held responsible for the abuse or neglect. So again, it's probably more common than you realise, and you will have seen the huge, very distressing cases, historical cases in the news, where it's often in hospitals or homes for people with a learning disability. They're the ones that we see in the media. So when you have organisational abuse, it can be a care home, it can be a day centre, it could be a GP practice, it can be a hospital, it can be a specific ward or unit on a hospital, and you'll often get other types of abuse with it. But what it means is the organisation is upheld for the abuse. So it's generally where there's a lack of support for the staff, there's a lack of clear policies and procedures, a lack of training, a lack of management support. So you often get neglect, you know, the adults who the organisation are responsible for caring for have kind of neglected them. You might get physical abuse, you could get sexual, you could get psychological, all those things. And they often take a long time to unpick, and there's usually a lot of people involved. Neglect and acts of omission. So again, it can happen anywhere. It's usually with carers, paid or unpaid carers, or in a hospital, that kind of setting. In someone's own home, it can, or day centre, it can be things like the person's not been getting their medication, they're not being given meals, they're not being given choice with their meals. So we find this in care homes. They're being made to get up, say at 6 a.m. in the morning, because that fits in with the staffing rotas. Now that's classed as neglect. People should have choice and control. So they might not be, I said medication, I'm just thinking through, they might not have their medication, they might not have adequate food, nutrition, hydration, all the things they might choose. They might not be given choice. They might not, their care plan might not be followed. They might not be given recreational activities, just sat in a chair all day watching TV. There might be no interaction with them. All those things can fall into neglect. In a home, you might get carers, the paid carers are not turning up, they're not being doing personal care, they're not providing drinks, they're not changing their clothes, all those kind of things. Self-neglect is, and this is one that we've seen quite a huge increase of during the pandemic, is when people self-neglect. So they generally disengage from services, and it's very, very hard to work with. It takes a long time, so people often disengage with services. They won't work to a care plan, they won't take their medication, they won't turn up for appointments. There's often, not necessarily, but often a lot of hoarding that can go along with self-neglect. You know, their physical health might really suffer, their psychological health might suffer. We had a very extreme case of self-neglect and hoarding recently, yet the adult involved, he had no kind of mental health issues. His mood seemed very good, yet he didn't have any electricity, any water. His property was a real fire hazard, couldn't get through the door, people couldn't get up the steps. He had like a rope pulley to get up. So we're seeing a lot of self-neglect at the minute. In Camden, there is a self-neglect toolkit which is available on the NCL GP website. It's also available on Camden Safeguarding Adults Board webpage, which is accessed through Camden Council. So it's a large document. It's about 40 pages, and it's something just to dip in and dip out of. So it can help you to, if you had a patient who was self-neglecting, or you wanted to learn a bit more about self-neglect, you can have a look at that. And it has some tools that will help you to understand what kind of mild self-neglect is, moderate or severe. It has some pictures of hoarding that, you know, are on a scale really. So it's quite good to dip in and dip out. We know with self-neglect, it's about building trust with the person. There's no quick fix. So it can take a long time. And of course, someone already mentioned radicalisation. So that fits in with those types of abuse, and it can be interpreted often when someone's been radicalised to commit terrorist acts, they're groomed, or they're always groomed. It's, you know, some people aren't happy with that term radicalisation, so that you might use the term groomed. It's helpful often to think of it in terms of grooming. And then the other types of abuse often come in with that. So there'll be some often psychological abuse. There may be some physical or financial abuse. Often it goes a bit hand in hand. So often the people who are being abused are quite isolated. So as well as having the care and support needs, they're often, you know, might not have a lot of contact with, and a lot of good networks with family, friends, neighbours. I mean, not always, but people who target people to abuse generally do abuse people who are quite isolated. And especially with prevent and radicalisation, the grooming element, it's people who are often in a low mood, bereavement, on the fringes of the community, of society, and that grooming starts by befriending. So that's the pattern it takes. You know, they don't just go in and ask someone to support some, you know, far right group, that there's the grooming, the befriending, making them have a sense of belonging to a particular group, and then all the other more dodgy things start happening further down the line, and the abuse comes into play once the trust is built with the person. Okay, any more questions on the types of abuse? I'll just give you a second in case someone's typing something. Okay, I don't think so. Can we go to the next slide, Joanna, please? Okay, so I mentioned at the beginning the 6 principles of safeguarding, which are in the Care Act. So we'll just go through them. What these, I mean, you're not expected to remember them. I keep them in mind because I've worked with them for so many years, but what they're really helpful at doing is providing a framework of, once we're aware of some abuse and neglect, then how to proceed with that. So that they're very clear. So the first one is empowerment. So we must promote independence and quality of life. And what that means is about promoting control and autonomy for the adult at risk. So we must presume that adults will make their own decisions, and we must engage them in discussions about safeguarding, about the concerns, as long as it's safe to do so. So of course we wouldn't engage in a discussion with someone if we felt the abuser, the perpetrator, was sat next to them. But if they weren't and it felt safe, or we felt they might present a risk to ourselves or our colleagues, we might not then. But if that wasn't there, which is the majority of cases, we would have a discussion with the adult themselves. Of course, if they lack capacity, we might not. They're the kinds of reasons, but otherwise we should be maximising the control people have over their own lives. So that's about empowering people. The second principle is prevention. So I spoke about this before. It's about having a proactive approach. So we don't have to wait until the harm's occurred, until the abuse has occurred. You might think, I'm not sure, I don't know what to do, I don't think I should do anything because I'm not sure there is some abuse or some harm. You should still do something. It's still about having a proactive approach to reduce the risks of harm or abuse, prevent person-centred services. So you're not expected to know that there's some abuse. That's the whole purpose of a Section 42 inquiry. That's where people often trip up. So you'd just be expected to have a concern. It might just be a gut feeling, so explore that. You might speak to the adult themselves. You might speak to a colleague and say, I've got this feeling something's not right. What do you think? You might ring me. We might have a chat about it. But it's about having that proactive approach to stop the harm occurring. Okay, next slide, please, Joanne. So proportionality, this is one that I think of a lot. So if we have especially quite a complex situation, so it's about having a proportionate response and being no more intrusive than is necessary. So it's about balancing the rights of the individual against the risk. So you know, if the risk is really significant, we would do far more, and we might be more intrusive and push things more. If the risk isn't very high, then we would have a lesser kind of intervention, really. And if we thought the risk was really low and someone said, I don't want you to do something, then we probably wouldn't. We'd just document it. If the risk was very high, then we may override that. But if they said, I don't want you to do anything, we may still make a referral. You might seek advice again around things like that, but proportionality is something. I had it with a case the other day where a GP rang me and is concerned about an elderly patient who seems more confused. Someone's moved in with him, someone he knew, and a friend of his is concerned. And we were discussing a referral to adult social care. I was saying I was thinking about proportionality. The friend helps him to manage his finances, so that there's no large sums of money gone from the account, and I was saying he may be a friend, there may be something concerning going on. In terms of proportionality, go back to the adult, the man, the patient, and have a discussion with him more, an open-ended discussion about what he wants. If large sums of money had gone from the account, then we may have made a referral that day to try and prevent any more going. So that's what proportionality means. Previous in safeguarding, every kind of risk, every concern, no matter how big or small, we ran in and did something and had a very paternalistic attitude in health and social care. So now the whole focus is about having a proportionate response. We would still do something, we'd still document. If we don't do something, we document. Why not? We might review that further down the line, but it's much more kind of fluid and flexible now. The fourth principle is around protection. So this is just that, you know, we have to focus on protecting the adult if they're experiencing abuse or neglect, and we should be offering support. Health and social care, when I'm saying we, should be offering support. There should be a protection plan in place, especially if it's gone through a Section 42 inquiry, and there should be good risk assessments if someone is experiencing abuse or neglect. Okay, next slide, please, Joanna. So there should be good partnership working. Again, if you remember back to the definition of safeguarding, this is covered there. A lot of these different frameworks all tie in together, and really a lot of them are saying the same thing, which is great. It gives a really strong, clear message. So this is about multi-agency, multidisciplinary working, that all partners should be working together, both to prevent, detect and respond to the neglect and abuse. So the detect's important, having an awareness, having professional curiosity. If you have a concern, exploring that a little bit more. So sharing information where appropriate. And the sixth principle is about transparency and accountability. So it's about professional engagement, ongoing assessment, clinical audit. It's about a fair and objective assessment of needs, partnership working, not making assumptions, putting our hands up when something's gone wrong and learning. So are there any lessons to be learned from anything? Being open, having an open culture, having discussions that, you know, with the adult, might be with family, with other partners, with other colleagues. So that's what the transparency and accountability is. And, you know, taking responsibility if something hasn't worked or something could have done better, and learning and moving forward with that. Okay, any questions on those principles? Okay, next slide, please. So making safeguarding personal agenda, this is a national agenda. Again, it's a framework as well as the 6 principles that tells us how to work with adults at risk. So I really like this, and this really has to be at the core of everything we do. So what making safeguarding personal says is safeguarding should be person-led and outcome focused. So by person-led, it means it's led by the adult at risk as much as possible, and it's very focused on their outcomes. It's called desired outcomes in the Act, and what it means is the desired outcomes are the wishes of the adult at risk. So the first thing that should happen if anyone has a concern, again, if it's safe to do so, is engage the adult at risk in a conversation about how best to respond to their safeguarding situation. So if you had a concern, you just say to them, look, I'm a bit worried about this, or someone's told me this concern, what's going on? What's your view? How do you feel? What would you like to happen? And that conversation should carry on throughout the safeguarding kind of journey, the safeguarding inquiry. So you might have, if you have a concern or a colleague does, or someone's told you something, that initial conversation. If a referral is made to adult social care and it goes to a safeguarding inquiry, the social worker would then continue throughout the inquiry, having that conversation, checking in with the adult. What do you want now? Is this okay? What would you like to happen? So it's very much led by them. They're very much given the choice and control over their own lives, which is correct. That's as it should be. They're involved. So it's about promoting autonomy and independence for the adult. It's about improving their quality of life, well-being and safety. So the overarching duty of the Care Act is a well-being duty. So that's kind of the golden thread that runs through everything in the Care Act, that we must in health and social care promote well-being. And that really links in with safeguarding in terms of promoting autonomy and independence and quality of life. What it means is we have to have a holistic approach. So in terms of well-being, we have to think about physical well-being, mental well-being and emotional well-being. So that's to stop us being blinkered and just thinking about the risk. We have to think wider than that and holistically, what is good for the person and what do they want to happen? How can we facilitate that really? And again, we must recognise, and this is back to the last statement in the definition, that people have complex lives and being safe is often only one of the things they want for themselves. So this is very much the case. I'm not talking about where the risk comes from other professionals. That's it, my slides went. I'm not talking about when the risk comes from other professionals or workers, students or volunteers. I'm talking about when there's some element of a personal relationship, so a partner, a family member, a friend. So often, as I was saying earlier, people, if there's a small risk, people will choose to live with that risk and keep the person in their lives. So what Lord Justice Mumby said, it's quite a long time ago now, but it's still quoted as what he said in some case law is, what good is making someone safer if it merely makes them miserable? So this really reflects what we used to do in safeguarding, where we would, you know, there'd be an element of risk. A grandson might be stealing £10 a week from his grandmother. We'd rush in and we'd take control. We wouldn't ask her what she wanted, and we say there's some kind of abuse. Obviously he would be really upset and angry and would disappear, and she'd be left on her own and without her relationship with her grandson, and we damaged the relationship for this £10 a week that she was probably more than happy for him to take, because he did her shopping. He maybe took her to the GP, took her to other appointments. He saw her once or twice a week. He may have been the only person she had contact with, and that's what happened in this case that Lord Justice Mumby is referring to. It was something similar, and we rushed in and took loads of action, and the adult at risk was left feeling miserable and lonely and isolated. So that's what that statement refers to. So it's not when the risk is really, really high, but if there's a kind of low to moderate element of risk, many people may choose to live with that if it maintains the relationship. We see it quite a lot in domestic abuse, and we know that that goes on. I mean, that's a bit more complex. There can be an element of coercion and control, but we would keep going back and having those discussions with the individual, monitoring the situation if they chose to stay living with that risk. But if someone has capacity, that is their right. Any questions on that? Any thoughts? Okay, next slide, please, Joanna. So consent. So this is just important to realise if someone has capacity and they refuse intervention, so they say, no, this is going on, but I don't want you to make a referral to social care, to adult social care, make a safeguarding referral, then we should, any professional should really respect their wishes. However, unless there is a public interest. So if it's in the public interest, we wouldn't. So this really relates to if the alleged abuser is a person in a position of trust. So it's a worker, a volunteer, a student, and not acting could put other children or vulnerable adults at risk, then we would have to refer, and we would be honest with the person about that, about why we were referring. Also, if there's a duty of care to intervene, then again we would refer to social services, to adult social care, and that would be where a crime, a serious crime has been committed, or we think a crime is about to be committed, then we would refer. So I think in terms of, is there a worker, a volunteer, a student involved, and are other people at risk? So if it was a care worker in a day centre, a nurse, for example, in a nursing home, a doctor in a GP practice, then we would have to refer. If we think a crime has been committed or is about to be committed, we would refer. If we think the risk is significant, then we would refer. So, for example, if you had contact with someone who was a victim of domestic abuse, and let's say the violence was escalating and you could see it escalating, and you became fearful for the woman's life and she was still saying no, don't refer, you would refer. If there's an element of coercion and control and duress and someone is saying no, don't refer, but it's because they're so scared and you think someone else is threatening them, then you may also refer. Again, you can get some advice from me around that if you're not sure, and there's the GMC guide to consent there, which is quite useful. Okay, next slide, please. So let's just quickly look at this case study. So Zoe is continuing healthcare funding and she has multiple sclerosis and has significant care and support needs. She's a wheelchair user and she needs support with personal care and other activities of daily living. So Zoe discloses to you in your professional capacity that she's been having sex with her domiciliary care worker, Philip. You advise her that this is inappropriate conduct on his part and that you must report it, so you must make a referral. Zoe becomes upset, telling you not to report him as she doesn't wish to make a complaint and that his visits are the only thing that she looks forward to. So should you share this information? Should you make a referral? If so, how and who with? So shout out, hands up, responses in the chat box. Aaron, do you want to say something? You're on mute.
So I'll probably first assess whether, the degree of, ultimately, would you seek help from seniors as well, or getting help from them to determine before kind of coming to a decision, or would you?
Yep, you could get some advice. You could speak to your Safeguarding Adults practice lead. You could speak to me, definitely.
But ultimately, I would report it. Yeah.
Okay. Yeah. Great. So Aaron would report it. Good. Let me have a look at the other questions. Answers. Sorry. Rachel says, I think I would make a referral as abuse of his role as carer. Yep. And possible risk to other patients. Juliet says she would refer. She'd share it with the domiciliary care agency. Any other thoughts? Okay, I'm conscious of time, so let's just move on. So let's have a look at this then. Next slide, please, Joanna. So yes, it should be shared. And the rationale behind this is, even though you've got no reason to query Zoe's capacity to consent to this sexual relationship, so she has capacity, so she has consented, and she doesn't consent for you to make the safeguarding referral, Philip is in a position of trust. So as I was saying before, he's a care worker, he's a worker, and he visits other people who have care and support needs. So the allegation really suggests that there's a transferable risk to other people. So a transferable risk means that other children or adults with care and support needs are likely to be at risk. So if he's having sex with her, it's inappropriate. He shouldn't be. He may be having sex or inappropriate behaviour with other people. Of course, we have to keep in mind it's an allegation. We don't know if it's true yet, but you're not expected to know. It's an allegation, so we must act. So yeah, everyone was right in terms of making a safeguarding referral. You may get some advice. You may speak to your safeguarding adult lead in your organisation, your safeguarding lead. You may speak to me. That's absolutely fine. You know, if you're not sure, don't just sit on it. Get some advice. Just no one should be going home worried, thinking, I don't know what to do. I haven't got a clue. I feel really uncomfortable. Speak to a colleague, speak to me. You know, we'll discuss it together and make a decision together. You must document exactly what Zoe's told you, her wishes and circumstances of the disclosure, but refrain from making any assumptions. So, and of course, you'd tell Zoe that you would be reporting it. You'd explain to her why, that, you know, he may be abusing other people. He's a worker. He shouldn't be having sexual relationships with the adults that he's working with, and it could present a risk, and therefore you have a duty. You have to refer. You don't have any choice in the matter. Often if you take it away from being personal, you know, then people are okay with that. She will be upset, but, you know, your priority is to protect her and protect other people. You would also offer her psychological and sexual health support services, even though she doesn't perceive herself to have been a victim of any abuse. So often victims of abuse don't perceive themselves to have been a victim, because part of the abuses can often be, not always, the grooming, the befriending. So, and they'll be fearful of losing that relationship. So, you know, she can be offered counselling, any other mental health, psychological services to try and help her get to a place to really unpick what's gone on and understand, you know, why she's, if it's happened, been taken advantage of, why she's been taken advantage of. Okay, next slide, please. So things you might consider, you know, I've just put these down for kind of thoughts to help you, what kind of things, questions you might ask, things you might consider, as well as the presenting things in front of you, the clinical and physical factors. So, you know, I always think, are there any existing or historical safeguarding concerns? I mean, that's not to fall into the trap of, oh, there's been 5 previously and they weren't substantiated, so she might be making it up. We have to take each concern on its own merit. It doesn't matter, but it gives me an idea maybe of what the history is, whether someone's, how vulnerable someone is. So you might think about that and look into that. If you've rang me, I would generally ask something like that. Is the care agency still going in? Are they involved? Is Philip still caring for her in that professional capacity? Has that stopped and the relationships continued once that's stopped? Might others be at risk, any other children or adults? I mean, you might not know, but that might be something you're thinking about. Also thinking about Zoe, like, what are her home circumstances and do they contribute to the risk? Does she live alone? You know, is she very isolated? What kind of support does she have? Does she not have support? Does there need to be some thought into linking her into other, I don't know, befriending groups, day centres, activities, that kind of thing. So it's just about professional curiosity, thinking around things, asking a few maybe open-ended questions. Okay, next slide, please, Joanna. So in terms of Zoe, the outcome was, as Aaron said earlier, then you can discuss with your safeguarding lead at the organisation. So that did happen. And then the disclosure was reported to the local authority MASH team. So that's the multi-agency safeguarding hub. And most local authorities have one. Camden have an adult MASH. It's very small. It's kind of virtual. You'll have heard maybe of children's MASHs as well. So in Camden, sometimes they're joined. In Camden, they're separate MASH teams. So you would make the referral to the local authority. They then discuss this with the police because it's a possible criminal matter. So what happens with Zoe is the police did undertake a criminal investigation. They decided to pursue that. Adult social care proceeded to a Section 42 inquiry, so the safeguarding inquiry, and the care agency undertook a human resource investigation. So this is it often causes quite a bit of confusion, these kind of different types of investigations. So you can have 3 separate investigations running concurrently, and often in complex cases you do. So you'll have the criminal investigation, you'll have the Section 42 inquiry, the safeguarding investigation, and you'll have the HR investigation. The criminal investigation, the police investigation, always takes precedent. So if the police say to adult social care, don't proceed with your Section 42 inquiry at present, then you wouldn't. You just wait, you postpone things until the police give you permission to conclude. Sometimes they all run together. You often share information amongst each other. Sometimes the agency will say, in terms of their HR investigation, they'll always suspend the person pending the investigations. And regarding whether to dismiss or not, they'll often say they're awaiting the outcome of the Section 42 inquiry and or the criminal investigation. So all of those investigations have a different function and they can have a different outcome. So please don't think because there's a HR investigation, then it's done and dusted. There doesn't need to be a safeguarding investigation. There may be, so there would still need to be a safeguarding referral. And likewise with the police, you may need to check out that they've made a referral to adult social care. So it's about having the communication between the agencies. Sometimes there's a misunderstanding. The police may think that you've referred to adult social care. You might think the police have done it. So just check out who does that. And if you've referred to adult social care, are they referring to the police? Should you? It's quite fluid who can do it. So they each serve a separate function. A criminal investigation is based on beyond reasonable doubt whether a crime has occurred. So they could prove that in this situation because Zoe had said, and let's say Philip, admitted it, and there was probably evidence that he'd done other things when they went to other vulnerable adults or children. But sometimes the police know that someone has abused someone, but they can't get enough evidence for it to proceed to go to court due to a lack of evidence, or they often say, or CPS, Criminal Prosecution Service, will say it's an unreliable witness. So if it's someone they shouldn't, but they do. If it's someone with dementia or a learning disability, they'll say it's an unreliable witness. So the CPS will decide not to prosecute. However, most people involved will know that there's been some kind of abuse. The safeguarding inquiry the function of that is to protect the adult at risk and any other adults at risk. And it's based on the balance of probability. So the bar's set lower. So you could have a criminal investigation where nothing really happens, but you can have a safeguarding investigation where the allegation is substantiated and a protection plan is put in place. And then you can have the HR investigation where usually someone's suspended pending investigations, and then dependent on the outcome, someone may be dismissed or may not. They may go back to work, and there may be some monitoring or conditions. Again, if someone's dismissed, then they should be referred to the DBS, and the organisation would do that, the disclosure and barring service. So what happens with Philip? He was charged with sexual offences against a number of people he'd visited, and some of them lacked the capacity to consent to the sex. He had employment checks previously, but they'd not flagged anything up. Zoe declined support services, but she provided a statement to the police. And following discussions with the local authority about Zoe's care package, she moved to direct payments, and she employed her own personal assistant. So for continuity, and she could build trust just with one person rather than having different carers going in. So it was felt that would reduce the risks if she's vulnerable to these kind of inappropriate sexual relationships again. So that was the outcome. Any questions on those? Okay, let's move to the next slide. So this is the referral form. It's on the NCLGP website. It's on the, if you put in Camden safeguarding, it will come up. So you can refer the form, you can refer, sorry, to the adult safeguarding multi-agency safeguarding hub with this form. You can also, this form isn't to be given to the public, it's for professionals. You can also email them and you can phone them. So the numbers on the Camden Council website, it's on the Safeguarding Adults Board website, and it's, I've put it at the end of these slides as well. Once you make a referral, you should be informed of the response by the MASH team, by Adult Social Care, which team it's been sent on to. Often they just screen it and kind of send it on to another team. Sometimes they'll do some fact finding, some kind of minor inquiries. They should get back to you and let you know. You can always contact them and ask them what the outcome is. If you have any issues with that, you can let me know and I'll go to the manager and ask for an update. Okay, next slide, please. So I've referred to the Section 42 inquiry, which is the safeguarding inquiry. So once you've made the referral, the local authority is responsible then for deciding what to do. So in some ways, the responsibility passes to them. So they will make a decision whether to proceed to a Section 42 inquiry. That's their statutory duty. And if they do, they will start an inquiry, a kind of investigation. So they might come back to you for more information. What the local authority can also do, it's within their powers, is they can instruct others to undertake the inquiry on their behalf. So particularly where there's a concern of a clinical nature, you know, they're usually a group of social workers, so they won't have that clinical understanding. I used to work at Moorfields Eye Hospital, so if we had a concern within the hospital and there was a particular clinical nature about it, they would ask the hospital to undertake the inquiry. So the hospital does that and then sends the report, the inquiry report, back to the local authority. They have to assure themselves that the inquiry is sufficient, it's a good enough investigation, it's balanced, it's looked at all the issues, and there's good actions to address the concerns and protect the adult and any other adults. If they think that there's some gaps, then they will challenge and come back, or they can start then another inquiry. So they're the lead, they have control over it, they can instruct you to undertake an inquiry, they can ask lots of questions, you should be sharing information with them if it's relevant to the safeguarding inquiry. And as part of the inquiry, you may be invited to, they're called different things, but in Camden, they tend to call them professionals meetings or planning meetings. You might hear the term strategy meeting or protection meeting. So that's just where in the professionals meeting, in the very early stages, the professionals get together, everyone talks about what their concerns are, whether they have any indeed, what their input is, how they know the person, just to help adult social care build the picture, help the social worker build the picture. And it's usually the team manager of the social work team will chair those meetings. So it's to help the inquiry officer, who's usually the social worker, build a picture, to gather the information and everyone to agree how to proceed. You may later on have a protection meeting, which is to look at the outcome of the investigation and to agree any actions, to agree the protection plan. Okay, next slide, please. So just to be conscious, in the Care Act, there's a duty of candour. So it's a duty to be open and honest over any care that may have resulted in harm or potential harm, any gaps, anything that could have been better. And that duty applies to all CQC registered health and social care services. And there's a focus on providing an apology and keeping the person, the adult involved, updated on the progress of investigation. So it's very much part of creating a positive, open and safe culture. So just, you know, that's the kind of framework that an inquiry exists within. Okay, next slide, please. So what legislation will, I'm very conscious of time, what legislation do you think may be available to safeguarding adults? I think we'll just go to the next slide. So there's a whole host of legislation which supports safeguarding adults, which we can use. So it's kind of in our bag to pull out as and when we need it. Of course, we've got the Care Act. We spoke a lot about that. We've got the recent Domestic Abuse Act, which is great, and bringing in a lot of statutory duties and powers. We'll come on to the Mental Capacity Act and the Mental Capacity Amendment Act, which introduces the liberty protection safeguards. We've got the Mental Health Act, which is under reform currently. We can use the Equality Act. We often use the Human Rights Act. If you read any case law, Article 5, the right to liberty, Article 8, the right to respect for private and family life, will nearly always be referenced by the judges. So Human Rights Act is used a lot. I think of the Human Rights Act a lot in very complex safeguarding cases, especially the right to respect for private and family life. It's a fundamental right that everyone has. Next slide, please. And there's some more. I won't go through those, but rights of entry for gas and electricity board, they're often used for hoarding. So Female Genital Mutilation Act, Counter-Terrorism and Security Act, that links to prevent agenda and radicalisation. And of course, we have the Modern Slavery Act, which is used quite a lot. So there's a whole host of legislation there, which is really good and gives professionals involved in the legal system very strong powers and duties to help us to protect vulnerable people. Okay, next slide, please. So safeguarding adults boards, they were introduced with the Care Act, and they're there to oversee the work of all partners within the locality to make sure there's good partnership working and the residents and patients and service users are protected within the area, and all the partners really give assurance to the Safeguarding Adults Board. So in Camden, they're called SABs. In Camden, it's Camden Safeguarding Adults Partnership Board. There's 3 statutory partners on boards, so it's always the same 3 partners: the local authority, the clinical commissioning group, and the police. Every board has to have those 3 partners, and then all the other partners will include the local health trusts, the fire service, probation and police service, the voluntary sector, community groups, and further education. So in Camden, there's Camden Safety Net, which I don't know if you work in Camden, you're probably familiar with. They lead on providing services to victims of people of domestic abuse, and there's Camden carers that are very active. They're responsible for doing the carers assessments that I referred to earlier. They also provide a lot of support to carers, so please do think about those. They're very creative, very flexible. They have a lot of groups. What Camden carers want people to do is to refer carers before it gets to the neglect and abuse stage, before there's a risk. It's that proactive, preventative element, so they can provide support to people to prevent a breakdown of care and abuse or neglect. Okay, next slide, please. Okay, so Safeguarding Adults Board has 3 core duties. One is to publish an annual, or sometimes it's 2 or 3 yearly strategic plan. So it sets out the priorities of the board and the partners for the following year. Sometimes it's 2 or 3 years. They publish an annual report that, thankfully, those reports used to be 60, 70, 80 pages long. They've got much smaller and more user-friendly recently, so they can be quite helpful. They're on the Camden Safeguarding Adults Board webpage. They can be quite useful to look at. They give a lot of data around the demographics of, within Camden, who's being abused, who's being reported for abuse, all that kind of things, the types of abuse, what's the most common, where the referrals are coming from, is it the NHS Trust, emergency services, GP practices, all those things. And they also detail the priorities, what the achievements have been over the last year and what the focus will be for the following year. And boards also commission Safeguarding Adults reviews. which let's look at. Next slide, please, Joanna. So Safeguarding Adults reviews are the responsibility of all Safeguarding Adults boards, and wherever an adult dies as a result of abuse or neglect, whether it's known or suspected, and there's a concern that partner agencies could have worked better, that there's some learning, then a SAR should be commissioned by the Safeguarding Adults Board. They can also commission a SAR where someone hasn't died, but the adults experienced significant abuse or neglect, and it's thought that the agencies probably could have worked better together, that there's some learning for the locality. So you might be asked to provide information for a SAR, and it's from the board. So they're usually quite tight turnarounds, especially in the early days for the information. So that does need to be given for them. I might contact you, especially if you're a GP practice, or the Safeguarding Adults Board manager might contact you asking for some information. So that would need to be provided. Okay, next slide, please, Joanna. So what is the purpose of a SAR? So there's 5, I've numbered them. There's 5 things there. I'll give you a couple of minutes. I'm just going to go get some water. My voice is going a bit croaky. So if you can read through those 5 things, and I'm asking, there's one that isn't the purpose of the SAR. So if you could just put the number in the chat function, I'll just be a minute. Number 4, number 4, number 4, 4. Any other thoughts? We've got quite a few 4s. Anyone else? Okay, 4. One last 4. Another 4. Great. Well done. Correct. Yeah. So the purpose of a SAR is not to apportion blame. So I know that it's often an anxiety, but that really isn't the reason for a SAR. It's to include the adult, any family or friends, to identify any learning. And it's really to focus on achieving good practice and any improvements that might help us. So sometimes it looks at individual practice within an organisation. Sometimes it's looking at a systems-wide approach. Often it's a bit of both. So it's a real focus on learning and improvement. And, you know, please don't feel anxious that if there is a SAR with a patient of yours, there might be some kind of blame. That isn't the reason for them at all. And often the chair of the SAR will give a lot of assurance around that too. Okay, next slide, please, Joanna. So we'll just skip through this. We don't really have time, and you don't need to know all this, but just the methodology can differ because of SARS. That's about how the information is collected. So the author and the will decide what methodology to use. There's always a chronology where that's just a list of the contacts that you or your agency will have had with the individual involved. We'll get a template, and we can either do that together. I might ask you to do it. It might identify whether there are any gaps in there, it might not. If you've had quite a lot of involvement, then you may be asked for another report, or it may be requested for an individual management review, an IMR, which looks more closely at, is there any learning, is there any gaps, was national guidance followed? If you've only had 2 or 3 contacts, then you wouldn't normally do an IMR. We've had that with a couple of practices, GP practices recently. They only had 2 or 3 contacts. So it's just a very short chronology detailing what the contacts were, the date, what the outcome was, and that's it. And then from all that information, the author from all the different agencies produces a report. The reports sometimes can take quite a long time. That's a bit of a bugbear of mine and a lot of other people. They cost a lot of money, and they can take 2 or 3 years to publish. So there's which by that time people have moved on, often to something else or left. So there's big focus on trying to streamline that and make them quicker, much quicker turnaround. So you may be invited to attend something called learning events and practitioner events. They generally run for an hour or 2, they may be 3 hours, and it's looking at the learning. And the purpose of that, it's multi-agency, it's trying to speed up the process and do it in more real time. You may be invited to a panel meeting at the beginning, and that is often to gather information. It's for the author, so just to be aware of that. Next slide, please. So the outcome of a SAR, again, there'll be a report that's published. The Safeguarding Adults Board will seek assurance from all the agencies that they're actioning the recommendations, so that will often be fed back to the board from all the different agencies. If you're in a GP practice, you might receive an action plan through the practice lead. I may ask for some assurance, I may keep in contact with you, ask what updates are happening, how things are going, or I might just speak to the safeguarding practice lead. And all SARs are published on Camden Council website, so you can always have a look at previous SARs. There's been 1 or 2 published in the last year. We've got 1 that's ongoing at the moment. And learning can take place on a smaller scale in your practice. So you may do a significant event analysis and audit. You may do some supervision and reflection. It might be group supervision. You might have a reflective kind of session, and safeguarding professionals, I can support with that. Okay, next slide, please. So just some themes from, this is quite old now, but I decided to keep it in because these themes are still here. So they're still very much, they're not just London themes, they're kind of national themes that always come up from SARS, or almost always. So one of the things is there's often a poor application of the Mental Capacity Act, or even if it's been applied, the documentation is poor. So please ensure that you document if you're referring to the Act, if you're doing capacity assessments, making a best interest decision, please ensure that that's documented. There's also templates in EMIS to support with that. The other thing is often information isn't shared as it should be between agencies. Often people assume information's been shared or someone else has shared the information, so they don't do it. They think, oh, I'm sure the social worker's done it, or the carer, or the family member, or the nurse in the practice, or the occupational therapist, so they don't do it. Please check out, because everyone is often assuming that someone else is sharing information, and it can often result in information not being shared. Often what we also see is inadequate risk assessments, or failure to kind of recognise escalating risks or do anything with it. Failure to involve carers. Remember, you can flag carers' records in a GP practice. You can refer for carers assessments. So you would ask the carer if they'd like to be referred for a carers assessment. Be conscious there can be a lack of professional curiosity around people's history and behaviours. We referred to that earlier. Just, you know, asking a few open-ended questions can often gather some useful information. And lastly, this one's coming up quite a lot recently in Camden, particularly around self-neglect, where we're seeing across the professionals involved, there's sometimes a failure to be persistent and flexible when working with people who are reluctant to engage with services. And it is very difficult, we know that, but it does take time to build that trust. And we must try and just keep going, keep monitoring, keep reviewing, keep trying to engage the person. So just to remind you or let you know that there is a high risk panel in Camden. We're reviewing it at the minute. So if someone has gone through a safeguarding inquiry, but the risk is still high and you and your colleagues still feel the risk is still there and you're uncomfortable with it, you and your colleagues can refer that person to the high risk panel. I sit on that panel. We look at the cases that come in and we think about what can we do to try and reduce this risk. So it's very much a strategic, supportive way of trying to support frontline practitioners to manage risk. There's also the Frailty MDT, which meets weekly or fortnightly, which is a fantastic group. It's been running for years. So and it's got a lot of health and social care frontline professionals on that group. It's a very dynamic group. So if there's an element of risk and you're struggling, or your colleagues are, you don't really know what to do, please refer the case to the Frailty MDT. And of course, you can come to your safeguarding leads if you're in a GP practice or your organisation. You can come to me for advice, and you can approach the local authority for advice. So there are those mechanisms in place where you shouldn't feel alone in managing a risk, especially where it's a very complex risk. You know, often there's no, or sometimes no easy answers, and it's just about thinking together about what we can do, monitoring, making sure there's clear risk assessments, and really working with our multi-agency colleagues on the ground. Okay, next slide, please. So I'm afraid we're running out of time. I'd said that this was the first time I'd done it. I was conscious that we may not have time to get to the Mental Capacity Act. So what I'm going to do is I'll put on another session. This still counts as a 1.5 hour. I'll put on, I now know that that's enough for a 1.5 session, and we're about halfway through, maybe a little bit more. I'll put on another session just to go through the Mental Capacity Act, and that will also contribute to your Safeguarding Adults training. So please look out for those sessions. Joanna, can we just flick right to the end slide? I think you'll be sent this slide deck, so you can have a look through it. That's great. So this is your, what came up, the useful contacts. So I think this is the last slide in the slide deck. So please note the local authority is where you make referrals to. So that's Camden Council, is the multi-agency safeguarding hub. I don't accept referrals. That's quite a common error that people make. They think a designated professional will take the referral and then pass it on. I don't do that. I'm here to give advice and support. And again, as I was saying earlier, the referral form can be downloaded. There's a link there from the NCL GP website. You can also, if you look under referrals and advice at the bottom of the slide, you can phone them or you can email them. There's the email address there. Members of the public can just ring them or email them. So just remember, the referral form is only for professionals. In terms of advice and support, I'm here to give advice. Also, there's Dr. Dee Hora, some of you may know her. She's the named GP for Safeguarding Adults. So I'm there, there's my phone number there, you can email me, and you can also email Dr. Hora if you need some advice or support. If you're not sure what to do, that's absolutely fine. If you have a general question, if you are sure, but you just want to run it by me or Dee, that's absolutely fine. Do contact us. Okay, any questions? I know that's been a very quick whiz through, and sadly I've not been able to cover the MCA. There is some slides, so you will be able to have a look at that, but I will put some training on, and I'll put some more case notes in the MCA. I took them out because I didn't think I'd have time, but I will do another hour or hour-and-a-half session on the Mental Capacity Act, which does link into Safeguarding Adults. So if you don't feel confident or don't know about the MCA, please do come to that session. Okay, any thoughts, any questions before we leave? Joanna, anything to say?
Only from me that if you'd like to receive a certificate for today, just to add your emails in the chat, and then we can also use your emails to share the future sessions for the MCA.
Great, that's fantastic. So you can send the details out, can you, Joanna, to people who've come to this session? Lovely.
Definitely.
Okay, great. Okay, lovely. Well, I can't say you've got much time back, maybe 1 minute. So lovely to meet you all, and hopefully I'll speak to you. And thank you. Take care.
Thank you, Sarah.
Okay, thanks, Joanna, for your support. Thank you, everyone. Have a good day. Thank you.